So my task is to talk about defibrillators in athletic venues, protecting the athletes and the spectators alike. And this is what we dread. The case of sudden cardiac arrest in the football field or any other sporting arena or even outside the sporting arenas. Screening is one solution. We can find the athletes, or some of them, or majority of them, by doing pre-participation screening and cardiac evaluation of the athletes, which is now recommended by the European Society of Cardiology and also implemented in most major sporting bodies, and even mandatory if you go to in big tournaments, FIFA tournaments, UEFA tournaments, and also recommended as best practice by the IOC. And this screening, of course, is well known to you, and it comprises of family personal history, physical examination, and a 12-lead ECG. And this is one part of the solution to trying to find the 1 in 300 who has an underlying cardiac pathology that could predispose to a major cardiac event. But screening is not always enough. This could happen. Also, this was a recent case, the Borjesson case in Italy, in a country where you have mandatory screening. So screening is not perfect, but we know that. So we have to have something else as well. And this is where it could happen. This is the slide I borrowed from Luis Retos of Real Madrid. This is what it could happen. This is in the park, on the field, but it's also in the stands where there are lots of people. And this is also a special location because it causes us different barriers and challenges to overcome. And first of all, the spectator is also at risk. This typical spectator may have a higher risk profile than the athletes, especially for coronary artery disease. The spectator may be less physically active, and indeed the majority of them are. But the excitement will be there, the catecholamine drive, the excitement of the sporting event, and so on. And also you have the additional effects of alcohol and drugs. And this might not be performance-enhancing drugs. And if you have an underlying cardiac coronary artery disease, for instance, doing physical activity may reverse the expected dilatation of the coronary artery disease on exercise to vasoconstriction instead. And this could also be the result of stress and during watching an interesting game. Is this a reality? Because in Sweden we prohibited in the CCU the watch of ice hockey games, especially Sweden playing Canada. That would be, because then that would be difficult for the heart patients to see. And now it's not prohibited anymore, and it may be wise to have that, keep that, because in this study, famous study in New England Journal of Medicine in 2008, you might have seen this. This is the incidence of cardiac events in Germany during the month of June in 2006, during the World Cup. And this is not the spectators in the stands. This is the whole population of Germany. And you can see all the, is this in the middle? Yeah. Okay. There's another one. Oh, there's a pen as well. Thank you. And all these peaks here coincide with the Germany games. So compared to the months, this is the year before, in June. This is fairly even with cardiac events in the whole country. The coinciding with the games, and it's a number of hours frame close to the games. There's increase in the whole incidence in the whole country of Germany. And this has been also shown, by the way, in Switzerland in the World Cup in 2002. Especially interesting here is the third peak, which is not so high. And this is the quarterfinal, or the game before that against Sweden, where it was 2-0 after 13 minutes. So, anyway, this has been shown before and re-performed also in Switzerland, as I said. But this has also been shown in a subsequent study that the incidence or the people don't get sick of watching football. But if you have an underlying disease, you may have a trigger event, also being a spectator. So the medical care at the sports events, it's difficult with all the big crowds. You need to navigate in large crowds to reach the patient. You may have no clear landmarks, you have frequent barriers to access, you have limited possibility to use motorized transport. You have multiple casualties, perhaps, in dangerous environments, and that could be also the spectators could be hostile and so on, and they could even refuse necessary medical care. And this I've seen also. I have chest pain, but I have to watch the game. Then I can seek attention. And then, furthermore, you might have stressful conditions for both the physician and the spectators. Other environmental conditions, lack of resources perhaps. They have the VIPs, which are special medical care, and especially prolonged time to hospitals. Even if you get the patient out, you have there is a problem of the traffic, especially here in places like in London. You have communication challenges. You can't use your mobile phone in a full arena, and you have to consider that. And you also have possibly the increased potential for even things as terrorism. So what we do use is some kind of equipment to safely guard. Being a team doctor at the international and national level, we know all these equipment. But what do you really need, and what is the role of the defibrillators? In these cases, you want to see a defibrillator fastly applied. And interestingly, you can look back, and the first time the defibrillators was used by paramedics in Brighton in 1980 show that lay-trained persons could be first responders and can use these external defibrillators both efficiently and safely. And there's been several studies looking at AEDs in a public setting. I will show some of these studies soon. And it's already, in America, it's recommended to have this in fitness facilities if the time to reach ordinary defibrillator or ambulance would exceed 5 minutes. First of all, we know that the time to defibrillation is the critical time. So for every minute, there's a 10% decrease in the chance of survival in case of sudden cardiac arrest if no CPR or defibrillators is applied. So the critical time to survival will be around 5 minutes. And if we applied the chain of survival according to Cummins, which was described 20 years ago, early recognition of cardiopulmonary arrest, which is a problem because these are always sometimes misdiagnosed, early CPR, early defibrillation when needed, and early advanced cardiac life support. All these together, we can increase the survival from as low as a few percent, which is the survival rate in the normal in a city, or if somebody falls down with a sudden cardiac arrest, up to 30-40% if all these are in the chain of survival is applied. And indeed, this can be shown in studies. First of all, this is a study from the casinos, which is a special environment. Might cause some people anxiety, others excitement, but it's a potential for trigger of arrhythmias. But it's also a place where you are under constant surveillance with cameras. So actually, some of the nicest figures we can see in collapse, there's been the time from collapse to defibrillator in this study, Valenzuela, was around 3.5 minutes. And the time to first shock was 4 minutes. And you can see here the arrival of the ambulance in almost all these studies is around 10 minutes. So it's too late. But there was a collapse to defibrillator time of only 3.5 minutes. So the survival here was 74%, which is enormous. And this is another study looking at casino arrests and comparing them to the survival of controls. This was at 65% survival in casinos compared to 5.5% outside the casinos. Should we say all should stay in casinos? The highest survival rate is, of course, in the CCU. Even if the patients are the most sick, that survival rate in the CCU is almost 100% in the short term. It's much higher than in the orthopedic section, for instance. And then it goes down and outside the hospital it's worse. But casinos is high. Another place where it's improving is the airports. This is a study from O'Hare Airport in Chicago, looking at 59. There is actually, if you have been to O'Hare, there is an AED very within 90-second reach, wherever you are at the hospital. And this is a place where many untrained people run. So you can have cardiac arrest. And they had 2 years' time, 21 cardiac arrests. And in this, there was ventricular fibrillation found in 18, and there was a successful resuscitation rate of 11 out of those 18, which is very, very good. And some of these were rescuers who had no earlier experience. So this is working, actually, in airports. What about sudden cardiac arrest in sports stadiums, then? It has been estimated to be around 1/2 to 2, around 1 in 500,000 spectators. And one of the recent studies from AZ Alkmaar Stadium in Holland looked at, had 3 sudden cardiac arrests in 800,000 spectators. This is a newly built stadium. So what they had was a CCU, they had a plan to take care of these patients, and they had on-site resuscitation of all these 3. But there was 1 in 300,000 in that study. I'm sorry about the disturbance of the picture of the slide here, but this is from Australia. And importantly, it showed that in a system where you have coordinated emergency life support strategy for delivery of a CPR and using AEDs, you could increase the survival almost up to the CCU standards. This was actually 24 of the 28 sudden cardiac arrests left the arena alive. And the 26 of 28 were defibrillated within 5 minutes, which is enormously good. But still, the arrival of the ambulance was 11 minutes, so it was too late. So this has to be done before the ambulance arrives. So we have to use the defibrillator if you have one. And this is a case of Hank Gathers, who died. He couldn't be rescued in the basketball NBA. No, he's a college player, actually, in the US. And this is some questions that frequently get asked about AEDs. Is it safe to use in this? This was a rainy condition in Portugal here with the death of Miklos Fair. But it is safe to use AEDs in wet environment, in rain, on ice, and also on metal surfaces. You have special considerations in arenas for lightning, for instance, could cause sudden cardiac arrest. You have the commotio cordis, and early defibrillation is very vital. And you have also exertional heat stroke, where you may need CPR. So there has been recommendations, and this is from the US in 2007, saying that to define the appropriate emergency preparedness in school and athletic venues and school settings and so on. So this was recommended in the school setting of sports in 2007 by the Americans. But there was no existing recommendations in Europe. And many clubs had a vast program in the arenas, but some had very less. So what we did was to undertake a study looking at 190 major arenas in Europe. From 10 countries, looking at this emergency preparedness, including AEDs. So 72% of these arenas had an AED present. Only 64% had a medical action plan, which was written. A majority said, we have an action plan, but they said it's not written down. So we can wonder where that plan is. And this is the support from looking here at the training, basic training. Only 65% train the personnel regularly. So this is clearly room for improvement. And especially interesting, we thought, was that of the 79 stadiums who had more than 5 minutes above the critical time to hospital, of these 79, 20 did not have a defibrillator. So in that case, they had to be very good at practicing CPR until the ambulance arrived, or has to do something about it. So following that paper, we had another paper, which was a consensus paper coming from the group of section of sports cardiology in the ESC, recommending a more comprehensive checklist to use at all major sports arenas with over 1,000 spectators, which should include the name of the medical director, somebody in charge, who will be also in charge of having a written medical action plan, including the level of care, the personnel needed, the medical equipment, how to communicate, treatment facilities, documentation, continuous quality improvement, and also collaboration with the ordinary emergency medical system. And this has to be individualized for each arena, of course. And this has now been applied for in time for the Euro 2012, and hopefully this, as for the screening recommendations in 2005, were then applied in the sporting bodies. We hope that these recommendations will be used by the sporting bodies for coming events. Just to look at the medical action plan again, we need access to early defibrillation. So the key is to reach, we don't say how many defibrillators you need, we say that you should be able to apply the first shock within 5 minutes. And also again, the medical action plan should be written and integrated, and you should have somebody responsible, so you can who is the one is responsible for the training, and also you should consider transportation time, probably measure the times in the arena to reach every corner in a full stadium, to reach every individual, and also to measure the transportation time to the nearest hospital in a congested traffic situation. But you don't get away with just buying the AEDs. You have to do something with them. You have to train. You have to have a plan. Who is the first responder? Who will then get on the pitch, in the stands, and so on. And that should be part of the medical action plan. And where you locate the AEDs and the number of AEDs. First of all, the training has been shown in several studies to be quite simple and well retained. And also, it's not related so much with previous experience. So many people, even laypersons, could learn to use these. More importantly, looking at specifically in a study by Beckers, AEDs by non-trained laypersons, if you do that in a mock cardiac arrest scenario, you could easily improve and shorten the time from mean time from arrest to shock from 81 seconds to 56, and you could the pad placement improves, and also the safety improves. So this is possible to do even if you're not trained. And what about how many AEDs are needed? There are some papers telling you about the equation, how you can calculate that for each arena. We won't go into detail, but this has been published by Crocco and then by Motika, and this is the paper I'm referring to. And looking here in one large stadium, they just needed and defined and looked how to reach every corner of the stadium and how long that took in a full stadium, and then they divided that, and they could see that you have only 3 minutes to reach the patient, and then you can divide the response time and see how many defibrillators you need in an arena like this. We hope also to consider that there has been some studies saying that possibly the conversion rate or the conversion to sinus in case of arrhythmias, malignant arrhythmias, might be lower in athletes, and that could be true, and then could be caused by, because this is not a healthy heart with a just blocked coronary artery, so to speak, because it could be structural abnormal hearts, cardiac pathology, or cardiomyopathy that could give less chance of defibrillation being success. But it could also be due to delay of defibrillation. Unprepared arenas, misdiagnosis, doctor and trainer and so on delay to reach the patient and interpret the athlete with the sudden cardiac arrest having small cramps, being misdiagnosed as possibly epilepsy and so on. And also the special considerations here might contribute to a lower success rate in defibrillation of athletes, but that's a speculation. But having said that, we have several cases of successful resuscitation in recent years. We have the excellent case of Mwamba here in London. We have a Swedish case you might not have heard about a hockey player who was resuscitated by the referee. And he survives and is well now. And also this is a recent case in Norway where they had a successful resuscitation on the football pitch. So it's happening and it's working if you have the proper preparedness. The UEFA is also saying, and they are now demanding from the arranging nations to provide much more equipment and safety around the games. So from this year, they have requirements. I'm just showing you part of this document. But the pitch-side medical equipment has improved and been a lot. So there's been a lot of requirements for pitch-side medical equipment, for emergency rooms, for ambulances at the games and trainings and so on. This is one part. So the EFA is putting pressure to be more prepared at the arenas, which is very nice. But also, this is an example of emergency rooms. And this is also an important slide because this is before all these recommendations come. This is from Real Madrid, showing where all these emergency rooms are placed around the Estadio Bernabeu. And when we asked Real Madrid, how do you know how many rooms you need and what equipment and so on, we don't know, so we have a lot. And that's all right for Real Madrid, but might not be possible for my team in Gothenburg. So what we need is a kind of idea what this plan should include. Importantly, though, what they have in Madrid and in many other places now, which is also recommended in this medical action plan and by UEFA, is that you should have this information also in the match program, so that the spectators know how to reach the emergency rooms in case of they need it. And we should also provide this information to the opposing teams, because now the big teams travel to the country where they will play a Champions League game before and have a big delegation and look at the arenas and hospitals and all that. And this should be unnecessary because you should be provided with this information from the arena where you play the game. And I'd like to show you this because this is my certification of doing the UEFA program of the doctor workshop. This is actually now provided to all the doctors of the national organizations, where you have a program, education of emergency happenings on the football pitch. And this is supposed to be disseminated now in each country. So we will have a course in Sweden for all the national team doctors, and then this will be disseminated and reach many of the team physicians. And this will be applied in all UEFA countries. And surprisingly, a fair number of these delegates didn't pass the test. So it's very useful to do this emergency testing with patients, with anesthesiologists, and so on. To conclude, we need a written, living, and specific medical action plan. You need trained personnel, and you have a medical director who should be in charge of that in each arena. We need equipment. AEDs the role of AEDs is important to actively save the patient in case of sudden cardiac arrest. Response times is the key, and for CPR within 1 minute. And that's not so easy to reach. We have to reach each patient, start CPR within a minute. And defibrillation within 3 to 5 minutes. This is the goal. And we can save lives and reduce chances of disability if we do this. And as I would like to just to recite what the American recommendation said, training in CPR and on-site AED programs are likely the only means of achieving early defibrillation and improving the survival from sudden cardiac arrest in athletes, and I would say spectators alike. So this is important. It's possible and it can be done. So thank you very much.